Okay, right. Although we've got a lot of people still about to join, I think we'll just start with the preamble, because what I don't want to do is cut into the discussions from our distinguished panelists and the presentations that they've got. So good afternoon to everybody. I'm Dr. Lisa Ackerley. I'm an environmental health practitioner and trustee of the Royal Society for Public Health and Director of Medical and Scientific Engagement Hygiene for Reckitt. Welcome to the fifth in our RSPH Sparks Debates programme. The Royal Society for Public Health is an independent public health charity dedicated to improving and protecting people's health. We're a registered charity and an independent Royal Society incorporated by Royal Charter with Her Majesty the Queen as our patron, and we work to improve health through membership, convening, policy programmes and training. We have been running webinars which give us the chance to discuss issues that matter to you. And so far we've covered public health and the state, co-production, public health systems, and what we really mean by public health. All sessions are recorded and are available on our website, initially for RSPH members. If you are an RSPH member, then you can also earn CPD points for attending, and just log into the members area and go to the webinar page to do this. We're delighted to be hosting this webinar today on COVID, the vaccine and mis and disinformation. Vaccine misinformation is an epidemic in itself. It may arise from true information that has been reconfigured or taken out of context, or it may be entirely fabricated conspiracy theories about vaccine and the pandemic more widely. Widespread misinformation about COVID-19 vaccines has included false or unsubstantiated claims about their safety, efficacy, ingredients, side effects and purpose, and has even targeted certain communities and put them off being vaccinated. So we've got some examples, for example, false claims that a COVID vaccination contains microchips that can be used to track and control people, false claims that the vaccine will alter human DNA, and false claims that the pharmaceutical industry has fabricated the results of vaccine trials or covered up harmful side effects to boost its profits. So to unpack all this, we've got a fabulous panel today who are going to bring a range of perspectives to this topic. They've only got 10 minutes each to present, and then after that we're going to have a panel Q&A session. So without any further ado, I'd like to ask Bobby Duffy to share his screen with us. Bobby is the Professor of Public Policy and Director of the Policy Institute at King's College London, who has previously worked as Managing Director of Public Affairs for Ipsos Mori and Global Director of the Ipsos Social Research Institute. So over to you, Bobby. Thank you.
Thank you. Thanks, Lisa. Actually, I've got no slides today, so I'll just be talking to you. But thank you very much for the invitation. It's really great to be here and such an expert panel. And I'm really looking forward to the discussion. Having seen some of other people's slides, we're in for a treat, and hopefully we'll get into some discussion with the audience on this too. So the main source I'll be drawing on is a joint study between King's and Bristol University, funded by the ESRC, which has tracked a longitudinal sample, some of them from the very start of the pandemic in April last year. And in recent waves, we've started to link to Twitter handles to try to get an understanding of online behavior. Only on that platform, unfortunately, but it does give us some useful indicators, which I'll come to. It's also quite a large sample of about 5,000 people, so we can look at smaller groups, which is useful in this type of area where specific groups are key. But first, I want to start with a positive message. I know there's lots of challenges here that we'll get into and lots of important implications, but start with the positive, that a very large proportion of the population are getting the vaccine when invited, and the intention to get the vaccine is high and has been rising. So, for example, in our latest study from April, 94% of those who say they were invited ended up getting the vaccine, say they ended up getting the vaccine. And among those who've not had it yet or had the invitation yet, we've seen a steady increase in the percentage saying that they are certain or very likely to get it, from around half in July last year to 6 and 10. And then lots more say fairly likely, etc. So it's only 7% now who say they're not at all likely or certain not to, which is halved in our study, our longitudinal study from July last year, 12 months ago. So more than this, though, one of the great benefits of doing these studies longitudinally, where we're tracking the same individual people over time is that we can see how attitudes change at an individual level, and how intentions and behavior differ at various points for the same individual. So one of the key points from our April study is that 52% of those who in December said they were certain not to get the vaccine actually ended up getting it when they were offered it. And 80% of those who said they were not at all likely to get the vaccine back in December actually ended up getting it. So at that kind of level, it's good news. It's we shouldn't forget that, as it may not have been how it played out. Certainly there was real concern early on about not reaching that level of intention and acceptance, although of course there's very high motivation in this sort of once in a generation crisis to take action. And then on that though, we shouldn't underestimate the importance of the practical in this, that people have very busy lives, and the enormous effort put into making vaccination accessible and simple as possible has been incredible in pop-ups, as well as the kind of general approach to this. And we should be rightly proud of that in public health and beyond. But the first message key is that wanting to and getting the vaccine is very much the social norm across the population overall. We know how important social norms are, and our perceptions of social norms are, and influence behavior. So that's a really positive finding and trend that we should keep repeating for people. Of course, that overall picture, as I say, hides a very large variations among particular communities, and it's a theme of the pandemic overall across all of our work, looking at all the implications, the social, economic, and other educational, other implications, that while it's a global pandemic that we're all subject to, how it's been experienced varies enormously between groups, depending on their existing characteristics and vulnerabilities. But it also is really important to realize that, and what the pandemic has done is also show that even though we've got very disparate communities within different situations, we're all really interconnected. And that's really relevant from a vaccination point of view, because if we leave clusters of the population unvaccinated, even relatively small clusters of the population unvaccinated, as well as the very serious direct impact on them, it also means we need to get even higher vaccination levels in surrounding communities to get to that herd immunity levels. And obviously it increases the chance of variants and other risks that come from that. And that's mirrored in vaccine. That difference between different communities is mirrored in vaccine reach and intentions, where, for example, ethnic minority groups and some religious groups in our studies had much lower vaccine acceptance and greater hesitancy. So in our study, ethnic minorities as a whole, 15 percentage points less likely to say they're certain or very likely to get the vaccine. Muslim populations, 20 percentage points less likely. And some of these populations are much more likely to hold those conspiracy beliefs. So, for example, the Muslim population are 4 times more likely than the population as a whole to think that the vaccine may cause fertility problems in the future, from our study in April. And the point here is not to single out just one population, because it applies in all sorts of demographic and socioeconomic groups. But it's a more general point that a lot of the work in engaging the hesitant is detailed, local, and specific, where key messages, key lessons that we know from across a range of work, where trust in the messenger is vital as well as the message. And we're very fortunate that the NHS is a very diverse organisation. One of the main delivery points of this is very diverse. And that no doubt helps in the sense of seeing people like yourself involved in this process. But it's also clear from our study that trust in health services is lower among some groups in the population, where it's in contrast very high in community and religious leaders. So again, lots of great local work going on, lots of brilliant case studies, building on those relationships, linking into community and religious leaders to give that sense of the importance of the messenger as well as the message. And of course, within this, misinformation is a key element to control, counter, mitigate in specific populations as well as the general population. And we can see the direct impact of misinformation and disinformation in great experimental work, including by people on the panel. I know Simon and colleagues have done excellent work in the UK and the US that shows pretty clear-cut effects. I won't cover that, as I'm hoping Simon will touch on that. But just to add from our latest study and a wider couple of points finally to wrap up. The first is that our work backs up the conclusion that conspiracy information seen online does seem to have a direct effect. It's not just that people who already believe in conspiracies are selecting in to look at that sort of information. It does seem to amplify concern. So it's not a neutral aspect of just a wide-ranging information environment. So how the platforms control this is really important, and keeping our focus on that is really important. The second point is that one of the key features of a network analysis that we did of Twitter interactions is that those who are hesitant or opposed don't all go to one group of places or sources. It's a very disparate set of sources rather than one big organized conspiracy theory network. This may be partly because of the actions of platforms to take information down, but it's also the nature of this quite disparate set of anti-mainstream groups. In fact, the distinguishing characteristic of the group in terms of where they look or go for information is not so much where they go, is where they don't go. That is their disconnection from mainstream online sources like big news sites or mainstream large accounts. So that is one of the key lessons, that disconnection from the mainstream as opposed to connection to a particularly organized set of non-mainstream information. So in some ways that's reassuring. In other ways, it shows the real difficulty of controlling and countering this, and the challenges that then may arise for long-term future trends beyond the pandemic. And there's lots of people focused on whether these sorts of anti-orthodox interactions lead to other forms of radicalization or extremism or declining trust generally in the mainstream and institutions. And it's really worth examining that in the online environment, whether that is spurring the increase in division, polarization that we see more generally. There's a great study examining, in a different context, examining 2.7 million social media posts from news accounts and politicians that found that the posts that were about opponents, attacking opponents, are the most likely to be shared. They're the ones that travel further and faster. This attacking the outgroup effect is much stronger than other predictors that we've come to know as being important in how online information travels, such as using emotional language. It's actually that sense of in-group versus out-group attacks that seems to get things to travel most. So that links to much wider issues of identity-driven politics, social relations, that we've got so much in focus right now with the incredible increase in focus on so-called culture wars in a UK context. And that's how I'd want to wrap up, really. That's something we'll be trying to explore more in the next wave of our study conducted over the summer. So many long-term implications from the pandemic, and understanding that could be a key one. Thank you.
Right, thank you very much for that, Bobby. It was really insightful and interesting as well, that it doesn't just obviously affect people's opinion. It's not just about people's opinions about COVID, but the longer, the wider ranging reach that you have. And one of the things I think would be really interesting to just collate, if we haven't already, and forgive me, the organisers, is to make sure that we know where to go to get further information from all of the speakers, but I'm sure that's in there in all the details. So I want to move on very quickly then to our next speaker, who's Dr. Simon Piatek, who's the Digital Analytics Lead for the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine. So over to you, Simon. Thank you.
Thank you very much, Lisa, and thank you very much, Bobby, for introducing our study. In fact, that is the study I will be talking about today. Just want to quickly check that you can see my screen and hear me okay. I'm assuming it's all fine. Can I share full screen? What I want to talk to you about today is actually trust. And when it comes to the space of vaccines, or prior to that, when we were preparing for the vaccination programs, the entire team at the Vaccine Confidence Project, we have been working for pretty much a decade, trying to understand trust around vaccination programs. Started a long time before COVID pandemic, And what comes with trust on the other side is vaccine hesitance. So what I'll present here today is essentially the study that Bobby already mentioned that we conducted in the US and in the UK, and all the examples, and I'm hoping you're going to like these examples of misinformation. I'm going to try to use them to talk about the main narratives that we've seen in the last 18 months. And obviously, you'll see how they are being portrayed using different media imagery. Unfortunately, I won't be able to share with the video, but it applies also to videos. So a brief introduction, the Vaccine Confidence Project. Most of you might know us for the Vaccine Confidence Index. It's something we've been working on for the last decades. We published the first one in 2015 and the most recent one in 2020, just before the pandemic. That is essentially the measure how vaccine hesitance changes over time in different countries, in different geographies. That is based on traditional surveys. Most recently, especially in the last 18 months since the beginning of the COVID pandemic, we moved on from this traditional surveying methodology, trying to discover new opportunities presented to us by big data and basically social media that gives us access to an enormous amount of data. That is essentially my role at the VCP. I basically conduct social listening, collect social media data, and try to analyze this data. And it doesn't matter what data collections we use, either traditional surveys or the new big data, social media data, we pretty much always apply the same rules when we're analyzing this data. We divide people or populations into three distinct groups: people who are anti-vax, people who are pro-vax, and this large group in between, the hesitant audiences. That's how they would be defined in communication space. So today, my presentation is basically focused on that group in the middle and what the two other groups are trying to do to shift those people either to the pro-vax side or anti-vax side. So I will start presenting a few examples of how the anti-vaxxers are working, how they're spreading misinformation, what narratives are pushing, and what techniques they are using to get those messages delivered to those hesitant audiences. And then I'll very quickly talk about that study and the actual impact of that, how it's changing people's perception. And then very quickly, I'll share you a few examples how the pro-vax side of this discussion, of this debate, is trying to do the same, trying to shift these people towards actually getting the jab. And finally, I'll try to offer a few very practical steps, what we should be doing to address these issues. So this is the first example of misinformation that we used in our study. As I said, I'll come back to the actual study and the design in 2 or 3 slides. That was basically, this presents 2 main narratives that we've seen since the very beginning of the pandemic. The political narrative to do with the control. Obviously, this one here is focused more on kind of right-wing conspiracy, but the same could be applied to kind of left-wing extreme movements trying to actually capitalize on this narrative that the governments are going to try to introduce this left-wing utopia on society, so that these are being used. It's a kind of political narrative. We're also seeing the economic dependency narrative that is very different in different countries, depending where you are in the world. You either certain values or certain dependency will be imposed on you, or you are the country that is imposing that, and based on that, different types of narratives are being developed. And obviously, there's the mandatory mass vaccination program that's been designed, obviously in my first slide featured Bill Gates, who has been the face of this pandemic. It's a bit unfortunate, but that is the case. Although it's changing a little bit, there are a few others joining, possibly Mr. Fauci in the US could be considered one of the faces as well, especially on the misinformation side. But this narrative of vaccinations that are being used to control population, mutate human DNA is very strong. So essentially, this meme that was pushed very, very hard on the misinformation side, on the kind of anti-vaxxer side, captures it all in a single image. And here are a few other examples of what we saw as being shared massively on social media. So obviously, we all know that vaccines do not work. We've known it for the last 30 years. We know that they actually cause the diseases that they were supposed to prevent, and we know that they're dangerous to children. We know, I won't be mentioning the name, but I'm sure we all know. And by the way, I'm actually using the same rhetoric as anti-vaxxers and people pushing these conspiracies are using, suggesting that everyone knows it, everyone shares these experiences. So kind of telling these half-truths. And the image on the right, which says there's obviously something fishy about the vaccines. So these are the examples of misinformation that we used in our study. We actually couldn't do that without Bill Gates. And by the way, if you don't know what the Georgia Guidestones and the First Commandments are, I very highly recommend that you look it up on Wikipedia. It's one of the main conspiracies as well. And obviously, this has been pre-planned and now is just happening. So in summary, basically, we've noticed that with all these, obviously, this could be memes, or this could be just text messages, or just simply words. These are the main narratives that are being pushed onto these hesitant audiences. This is basically using fear to deliver these messages. This is not new. We've seen very similar mechanism, for example, during the migrant crisis in 2016 in Europe, that is being used in politics as well. So the technique as such is not new. The only difference is that for the first time ever during this pandemic, we are seeing this being used in this vaccination space at a large scale, obviously, because this is a global problem at the moment. We're seeing that the anti-vaxxers are much more responsive than the pro-vax side of things, especially when it comes to engagement on social media. We are also seeing that they're much, much better with the actual direct engagement with hesitant audiences. And they're really, really fast, and they're very responsive. This is not surprising. If you think how science is communicated to people, obviously it needs to be checked, it needs to be verified, and all this takes time. So in order to respond to a certain narrative, we as scientists, we do take time. So we're in a kind of this disadvantaged position, whereas these people, they can say things almost immediately. They can respond to questions raised by these audiences. So what we did about this, we wanted to find out what is the actual impact of this misinformation on populations, on people, and basically on the willingness of people to accept the vaccine. So this study was conducted in the US and in the UK about this time year, I think it was August 2020, in both countries, representative samples. And the design of the study was very, very simple. We asked people a simple question: how likely are you to accept COVID-19 vaccine when it becomes available? Because we have to remember that was even before we actually launched the vaccination programs in the US and in the UK. Then we showed these people all those examples that I've just presented to you, including the one you can see here on the right. And then immediately after that exposure, we asked them exactly the same question: how likely are you to get your jab now? And there are two main results that I'd like to report to you here. The first one is point number 4 here. The exposure to misinformation reduces the intent to get the vaccine, especially amongst those who said that would definitely get the vaccine in that pre-exposure question, by 6.4% in the UK and 2.4% in the US. If you take those numbers and look at them from the perspective of the size of the population, you can see that there's a huge number of people that could be potentially, or most likely are, affected by misinformation. It just shows how important an issue this is. And the second finding we had is actually illustrated by this image here on the right, that the scientifically looking misinformation actually increases vaccine hesitancy the most. So from all of these images that I've shown to you, the funny images of Bill Gates or these conspiracies, either the political or the kind of related to health or safety of vaccines, do not change that perception too much, but it is the scientifically looking misinformation that is extremely risky. This has got very serious implications because as scientists, we obviously, when we're presenting information, the true information about vaccination programs, by the nature of our communication, we present it as scientists. And those people who are pushing misinformation, they're using pretty much the same technique as us, but they're changing the context. You're just adding a little bit more to that, just to make sure, just to see that doubt amongst population. And in contrast to what I've showed you before, I want to show you now how we, as the, say, pro-vax group, either the school or the PhD England or others or NGOs working in this space, we're trying to communicate our messages and how different it is to what the anti-vaxxers and people spreading misinformation are using. So this is what happens if you start searching for vaccine, COVID vaccine on Twitter. You're presented with this information with a big blue button. If you click on that, it takes you to the official NHS website. We are not saying this is wrong. We're saying this is perfect, this is great, but this most likely works for those who already are pro-vax, people who are already convinced. It doesn't necessarily work for those who are hesitant, because one message for all doesn't work in this space, and we've tested and tried that with many interventions on social media. So what can we do about this? How can we address this? So obviously, I think by now everyone agrees that communication is absolutely critical here. It needs to be evidence-based, and we all absolutely agree. And it might not have been the case at the beginning of the pandemic, because obviously we'd never had enough data, but now it all needs to be 100% data-driven, because there's plenty of data to prove the science, especially in the UK here, the vaccines do work. But I just want to raise your attention to point number 4 here, that our approach needs to be more innovative. We need to do it differently, and it needs to be more similar to how the anti-vaxxers are doing it. And we very much here at the VCP believe that it is this crisis, this misinformation crisis around vaccines, is actually a moment of opportunity. So that is quite positive. We can come out stronger of this crisis, and it could actually help us with communicating information about other routine immunization programs that we're going to be focusing after COVID. And how do we do that? And that's my main screen. This is what we've been advocating for the last 18 months when we were talking to governments, either NGOs or social media platforms. That first of all, the communication should not be about the individual vaccine unless it is absolutely necessary. There were a few cases in the last, say, 10 months that it was absolutely necessary to focus on the brand. But other than that, we should be focusing on vaccination as such as a program. It should be absolutely about conversation. We should not rely on this top-down communication strategies. The example of Twitter feed with that big blue button and then one solution for all, the NHS website, is how the top-down communication is being done. This doesn't really work for hesitant audiences. And the final 2 things, we need to be able to find new trusted messengers. Historically, it was obviously doctors, physicians, but I think now the list of people who should be delivering this message should be increased, obviously, depending on the country, on the geography. So for example, for certain minorities here in the UK, these could be imams, or these could be priests who would not normally be your messengers when we would be working on programs to deliver routine vaccination programs. And finally, the content, the actual message is the new king. It does matter what we say, but it absolutely also matters how we say that, how we package that. And I hope by showing you those 2 very contrasting approaches, obviously it has changed now. We kind of we are going in the right direction, but the content is the king, and we need to be able to engage with people where they are on the platforms that they are present, and actually using the language and the sort of the type of messaging that actually work for them. And we now have enough data to actually develop this type of content. So that's it from me. Thank you very much.
Thank you very much, Simon. That's really fascinating. It was very interesting to hear about the two main methods that the anti-vaxxers are using, and also the change in approach that's needed, because one size isn't going to fit all. And I think that's those are really key takeaways. Thank you very much. And obviously we've got the question and answer session shortly after we've heard from the next three speakers. So that brings me on to introduce Noreen Khan, who's the founder of an organisation called NEESIE, a platform which provides supportive friendships and help for single mothers. So it'd be really interesting to hear your take on this issue. Thank you, Noreen.
Thank you very much, Lisa. Good afternoon, everyone. And firstly, apologies for the nasally voice. I am suppressing a bit of a head cold here. I don't usually sound this male. So thank you so much for joining from all over the world. I've noticed some people are. So I'm just going to share my screen and take you through a little whistle-stop tour of the program that we've been running. So as Lisa mentioned, my name's Noreen Khan. I'm the director and founder of an organization called NEESIE. A lot of people sometimes pronounce it Nessie because they think I'm the Loch Ness Monster, but I can assure you I am not. So in running this organization, NEESIE, and facilitating support and prosperity for single mothers and women with children, we come across a plethora of issues in the community, specifically inner city communities, every day. What we found during the beginning of the pandemic was quite astounding, certainly a new journey for myself. So what I'd like to take you on is, as I say, a little journey about the what's, the hows and the whys that this pandemic has affected families, communities, and where some of these frustrations are actually stemming from as well. So with regards to some of the misconceptions or disinformation that we have running out there, we have all of the usuals that we know about the 5G masks. There's, it's unsafe because the vaccine is unsafe because it's been developed so quickly. These were misconceptions that we were being inundated with from many of the families that we deal with. Now, looking in perspective, in Bradford alone, we're currently supporting over 4,200 families. And this could be anything from economical support to emotional support, which is your mental health and well-being. So what we found when we were being engaged with these inner city vulnerable communities as it is, the messages that they were receiving, whether it be on the WhatsApp messages, on social media, was the usuals that you will all have heard of already and you'll be aware of. But it's about understanding why that they are buying into these misconceptions. We were hearing the craziest of misconceptions and myths that were coming forward. Now, what these misconceptions were actually causing was a breakdown of family networks. We had couples in families where they were refusing to send children to school. The father may be refusing to send the child to school, worried that the school was going to inoculate a child without the parents' permission, and then causing arguments between the family. The frustrations were then resonating into physical abuse, and we were there having to then support the mother and children in abusive households. Paranoia started to step in with things like tracking devices were going to be put in, the side effects, the causes of infertility that's already been mentioned by previous esteemed panel members, and that the poorer were only being affected by this. And just for good measure, some of the craziest of misconceptions was that they wanted to reduce the population so that faster access to the internet was there to download some of the Netflix movies. I wish. But yes, so these were some of the misconceptions that we found out from our grassroots research that was coming. Now, let me also stress, everything I state in my following slides are on the basis of assessment that's come back from the communities and our research during our COVID leadership program. At no point is this my opinion. At no point are these my set beliefs or non-beliefs. So, but naturally, as a pro-vax, as someone that's wanting to help Britain reopen again from this, it's very important for me working in the communities to understand where this is stemming from and why. Now, within our COVID leadership program, which I will go into detail in the next couple of slides, but we have to understand why these misconceptions are coming forward. We know that there's poverty factors, the health inequalities, disproportionality, the broken homes, deprivation, poor housing. Now, being poor is not a choice. For many of these inner city communities, it's on the back of poor policy. When they are hearing narratives consistently coming forward that, for example, these intentional social housing structures, and then there's narrative coming from government or the top saying that overcrowding is one of these issues of super spreading of COVID and the virus. Well, what we are hearing from the community and these already frustrated, vulnerable communities at large are saying, well, the Prime Minister got COVID, Prince William got COVID, and they don't live in high-rise overcrowded flats. So the narrative has to start changing in trying to connect very clearly and in a trusting manner with these inner city communities. There's also generational habits which are being picked up, and how are we starting to change this? When we see youth centres being shut left, right and centre within these cluster communities, and we're not able to change those intergenerational habits, we are forever going to continue to have what we've always done. So the disablement of support structures are a major factor for believing in these misconceptions. There's the counter narrative. Now, previously for vaccines or any pandemic, there was never a counter narrative available. Now, as we've already heard so far, that because of social media and the internet, there now is a counter narrative available, which is why we are seeing this epidemic of the internet issue or the spread of misinformation so much more greater. Now, the internet as an infrastructure has become a lot more reliable. Because previously it was a top-down approach from the leader at the top, from the Prime Minister. Once upon a time, they were very trusted. And now what we're finding, because of the mixed information that we've seen descend from the top, what we're seeing now is that the roles have reversed, and now we're seeing it's a bottoms up. It's very grassroots information is stemming its way through social media. And hence the speed of misconceptions is much higher because of this access that everyone has widely available. So the trust in the internet now is greater than the leadership. And these factors combined have enabled the pandemic of misconception to spread like wildfire, bearing in mind we already had these factors of health inequalities and disproportionalities coming forward. How are these anti-vaxxers or these misconceptions being spread very quickly? Now, we've already mentioned some of the factors that anti-vaxxers are aware of this. And what we found is that they know that these frustrated communities, they're actually not anti-vax. They're probably not against a vaccine at all, because vaccines we've been having blindly for decades. We've never questioned it. When our children are born or when we go abroad, we've never questioned widely vaccines before. But what we've found now is that the anti-vaxxers have cottoned on that these people who are already frustrated from inner city communities are actually anti-establishment because of these inequalities, because of seeing that BAME backgrounds are more likely to be manual workers, because they don't get a chance in middle to senior management. The sophisticated use of social media, Twitter retweets, Facebook, one message has a potential to reach 5 million people in under 2 minutes. Now, anti-vaxxers are aware of this, but also understanding that these anti-vaxxers network have over 58 million followers, and it's an industry. It's a business industry worth over $1 billion a year. And as a vulnerable person who's very unsure, I wouldn't go as far as calling them an anti-vaxxer, but certainly someone who's hesitant of everything that's going on because of the misinformation and the delay in the right information to inner city communities. When you hear that actually these anti-vaxxers are making money on the back of your misery, on the back of you not equipping yourself with the correct health going forward, I think they're more likely to start to sway, and we've certainly found that. So how did we find this? What we created in our organization, thanks to the foresight as well of our chairwoman, we realized that by summer of last year, when we knew there was these hesitant communities in just believing in the virus, what would be the impact if and when we did have a vaccine? how were people going to take this up? So knowing that our USP, our unique selling practice that we have, is working with young people as well for social action programs. So in doing so, we took this a step further. With thanks to funding from Power to Change, an independent funding body, our idea of creating a leadership program where we were upskilling young people from BAME backgrounds, from predominantly health and social care backgrounds. So they're at university studying health and social care. And this is purely with thanks to Alison Hartley from Bradford University, Heather Zaman from Heather University, who realized that this was a great opportunity for their students also. So this program that we had created was to ensure that we can equip 20 young community public advocates that will have the right, correct, authentic information regarding COVID, the virus, and the medical and clinical information behind this as well, to then go out and have community COVID conversations. Now, this is with people at all ages from BAME backgrounds, as we knew that that's where it was disproportionate in terms of the take-up and the belief of the virus. So this COVID leadership program and lead programs I have been running for over half a decade. And what we created was a four-stemmed approach. One, to upskill these young people. The second, to ensure that they have a leadership qualification at the end of it. So they're an accredited qualification. That ensured that we were able to have the professional voice that was out there working with communities. They also have created a policy paper that was presented to Nadeem Zahawi, the vaccine minister, just a few weeks ago, excuse me. And what we wanted to ensure was that the research that they were pulling from the community and the actual conversations, that there was a solution for. So, and also a leadership summit, which is yet to take place, where Nadeem will meet with the students in London face-to-face in October as well. Now, this knowledge and experiences that the students took part in and had these conversations with the community at large ensured that we were able to have those specific and targeted conversations and outputs, which were absolutely astounding, if I may say so myself. The straight talking messages, the simplified perspective that these young public advocates were able to do. And I'll give you one example, if I may. So for example, one of the key ones coming from inner city communities was, how was it physically possible for a vaccine to have been created in such a short space of time? Now, to try and explain this clinically, even I wouldn't understand. Now, I know I'm sandwiched between such amazing esteemed panelists who are all from a medical and clinical background. I do not come from that. So I too need to understand it in a simplified form. So what does this look like? The innovation of the young people and having their intelligence create this program as well meant that one student from Bradford was able to completely change an entire community by one example, and saying, just like when you go to a restaurant, now Bradford's curry capital, if I may just kind of bradvocate there, but for example, when you go for a curry at a restaurant and you will choose what variety you want, what he decided to do to this inner city community was to say, just like when you go there and you will choose your variant of your spice or your curry and your sauce, and the same applies to the vaccine. Vaccine preparation has been around for decades. They have been working on vaccines for all sorts of things. So creating the baseline for the vaccine was nothing new. But dependent on the variant of the virus that's coming forward, that meant that once the scientists or the vaccine specialists were dealing with this variant, they were able to then tweak and understand how strenuous this specific virus is. And this was on the back of a young person's understanding. So what they were able to do was to understand that now we are in an emergency. It's a global emergency, and all financial resources meant that all these professionals and scientists and clinicians around the world were able to pull together and work at a faster speed because of the unlimited pool of funds that was available to create the vaccine. Now, that's one simple way to answer this very complicated question that seems to spread like wildfire on how has a vaccine been created so quickly. And yet the community, they bought into that, they understood that, and they were there recalling their doctors for their missed appointments. Now, some of these outputs that we have, I mean, I could go on forever with examples. Some of the worries we have as well that we were trying to turn was the staff within NHS itself. Now, whether this is down from the porters to some senior members, when they too are hesitant, the worry for people like us in the community trying to send those reassurance messages is always going to be exacerbated when you have someone, no matter what the position in NHS, is too hesitant themselves, because their message is going to spread much faster within the realms of working in a hospital or a doctor's surgery or a care home. So we really made sure that these COVID public advocates were out there working with NHS staff also. So these now upskilled young people, you know, the knowledge that they've brought back in the policy paper, it's made sure that I now have a renewed responsibility. With all of this, I have to go out there and find the right platforms where this public awareness can be used greater, and that I have more of a policy influence on this research that I have. Where I will find that is yet to be found, but we certainly know that understanding communities intrinsically is the key here. We really have to start listening to the communities, because not everything they say is wrong. Inner city communities are not dumb, but by understanding and listening to them, what we have been able to do is turn the tide and create a positive impact for inner city communities. I hope that's helped understand our programme on this whistle stop tour, and I'll be happy to answer any questions at the end. Thank you so much.
Thank you so much, Noreen, for such an energetic presentation and a good news story, which, you know, we all like to hear. And it's great to see how, you know, you managed to turn around attitudes in the face of quite a lot of adversity as well. So I'd like to move on now to Dr. Melvin Sandkast, who is a physician scientist specializing in vaccines, infectious diseases, and global health. He's a medical director at Takeda, a digital health expert for the World Health Organization, and a TED educator. So we're very lucky to have you. Over to you then, please.
Thank you, Lisa. I am just going to share my slides now. Can you see them?
Yes, we can see them. That's lovely. Thank you.
Okay. So thank you very much. Thank you, RSPH, for the invitation to be part of this webinar. My name is Melvin Sanikas. I'm a physician scientist working for the biopharma industry, but I'm also a technical consultant for other organizations working on tropical diseases and global health. Although I'm now based in Switzerland, I spent a big part of my career in Asia Pacific and Africa. And even before COVID-19, I have been active in science communication and writing news articles and op-eds since 2016. I got myself a Twitter account 4 years ago and started to simplify scientific news and debunk falsehoods online. And since then, I have had a significant experience talking to people not only online, but also offline on misinformation, especially about vaccines and more recently, COVID. Misinformation is one of the most serious threats to public health, and it is most damaging when it fuels vaccine hesitancy. So Simon briefly mentioned this earlier. I want to start by clarifying what vaccine hesitancy really is. Vaccine hesitancy is complex and context specific, and it varies across time, across places, different geographies, and different vaccines. It refers to delay in acceptance or refusal of vaccines despite availability of doses. Now, it's important to highlight this because we always hear about vaccine hesitancy in the context of COVID, but in reality, in many places globally, there are no vaccines available for everyone else who wants to get vaccinated. So how can one be hesitant to take something that is not actually available? At its core, vaccine hesitancy results from the decision-making process and reflects a variety of factors. So we talk about confidence, we talk about complacency, calculation, collective response, convenience, and I just want to define these terms. Vaccine confidence is the trust that patients, their families, and healthcare providers have in vaccines, and the process that led to vaccine development, licensure, manufacturing, and recommendations for use. Vaccine complacency exists where perceived risks of the disease is low and vaccination is not thought of as a necessary preventive action. Calculation refers to engagement in extensive information gathering that affects our perception of the vaccine. Collective response is our willingness to protect other people, and convenience is related to availability, affordability, and accessibility. COVID vaccines are free, but they are not accessible to everyone, especially in developing countries. And all of these 5 C's are susceptible to false information, and false information affects our decision-making to get the vaccine or not. And vaccine decision-making is really complex. It's not just the information or misinformation we receive that influences our decision. It's also influenced by our educational background, our experiences, our beliefs, our social networks, and many other things. If the facts given to us are consistent with our beliefs, we tend to accept it. But if not, we tend to reject the facts. So giving people facts alone, giving people information alone, do not guarantee a change in their thinking. To have a better understanding of the misinformation situation, we should note that 20 years ago, the flow of information was for the most part one way. That is no longer the case. Inaccurate information spreads widely and faster, making it more difficult for the public to choose or listen to advice from trusted sources. It is also important to remember that this is the first ever pandemic in the internet age, because during the time of SARS-CoV-1, the first SARS, not everyone had access to the internet. Now, almost everyone in the world has 24/7 access to the internet, or at least some form of regular access to the internet. And anyone can just create a meme, an infographic, or a video, and those with the most outrageous claims get shared the most. Also, trust in experts has been declining. And the major reason for that is the way we communicate science. While scientists are generally very cautious in their claims, the sound bites and memes that the general public consume ignore the nuance and uncertainty. And in this pandemic, most of the time, the answer is complex, or we do not know yet, or we're trying to find out. But most people are not satisfied with that. So we look for answers that are more simple to understand. And that's where misinformation comes in and fills the gap. We also have to rethink how we communicate science. We need to be mindful that what science is understood to be and what it is used for can come down to something as simple as how it is communicated. We should always bear in mind that we do not talk the same language as others who are not in the field of medicine or science. If we want to have the best science woven into evidence-based decision-making in the government, in policy-making, and in businesses, and in the community in general, the scientific community needs to train researchers to be excellent communicators of their work and of the contribution of their work to society. And I think I want to end with this slide, just to emphasize that communication is a key tool for success of any vaccination program, including COVID vaccines. And inadequate or poor communication about vaccines, together with misinformation or deliberate false information with intent to deceive, which is disinformation, they can significantly contribute to vaccine hesitancy. And it is also important to remember that in a global crisis, such as a pandemic, all affected people take information differently, process information differently, and act on information differently. So it is really crucial to have the right message at the right time to the right people using the right medium. Thank you for your attention.
Thank you very much, Melvin. I really enjoyed that presentation, and it's so interesting. It sort of mirrors some of the research I've done as well about, you can't just give people information and expect them to change their behaviour. But the fact that you looked at how this pandemic is actually different to previous ones, because we've got the internet messing about with all this, and of course that the communication is really important. Again, something close to my heart. How can we extrapolate what scientists have found and put that into the right messaging so that we can persuade people, basically? This is a marketing exercise, if nothing else. So thank you very much. And obviously we're going to have some questions later, so we will speak to you again soon. So our final speaker today is Dr. Venu Manivagaskar, who's the founder of COVID-19 Infographics and a trainee doctor. So I'd like to hear what you have to say on this subject.
Good afternoon, everyone. Thank you very much for having me. I just want to start off by apologising for my voice. It was a very emotional evening at the Monica Vossa household on Sunday evening, and I'm still recovering from it. So I'll try my best to enunciate and get my share my points. So I'll start off by sharing my screen. Okay, so thank you very much for the introduction, Lisa. So my name is Venu. I am I'm one of the co-founders of the COVID-19 Infographic Initiative, and I'm actually a foundation year one doctor who qualified prematurely last year in response to the pandemic. So I've sort of, been experiencing a lot of it as well. Now, it wasn't too long ago when these words, I guess famous words, were uttered by the Director General, and it had sort of an aura of a premonition, which unfortunately came true with quite sort of devastating effect. Just going to click through. So the case study that I use in terms of countries which probably have suffered most obviously, Brazil, I mean, where it was coming from one of the highest authorities, sharing, misinformation over and over. And we started seeing some of the effects of it, quite recently as well. I mean, there's plenty of factors involved here, but the misinformation and the level at which it was coming from was clearly a big contributing factor. And whilst we've explored how misinformation works at a higher level, I kind of want to bring it down and downscale it to the individual, kind of similar to what Noreen shared with her work, with the work that Nisi have been doing, and bring it back down to sort of the ethnically diverse individual. So I just want to paint a bit of a situation here. Here we have an individual who's sort of ingrained in a community, and has found comfort in where she's been growing up. Ever since she either moved to this country or was born into this community, and suddenly towards the start of the 2020, they're all sort of plunged into this world of uncertainty. And in the absence of information which was accessible to them, they start getting sort of pinged with, these sort of messages from social media. And suddenly there's this, feeling of collective sense making within the community where everyone's pitching in together to try and make sense of what's going on. Especially, the uncertainty was quite widespread. And a lot of these information that they're getting sort of pinged with starts to fit their narrative, so they start to take it on, this idea of identity driven information. And suddenly you get more and more of these messages which start flowing in, which start to sort of reaffirm your beliefs and try to strengthen the sort of misinformation that's been coming through. And really this was the situation that we saw in the first wave. We had this sort of vacuum of accessible information which was being filled with this misinformation, especially for the sort of minority communities, and the effects of it were quite clear. Questions were being raised towards the start, and this was the case even before we started. The vaccine campaign even really took off, so it wasn't a surprise to see news articles such as these coming through. And this was really the motivation behind the initiative that we'd started. That being COVID-19 infographics. I'm just waiting for the slide to load up. So essentially, we're a group of doctors, volunteer students from various backgrounds, translators, and various organisations. And our ultimate goal was to try and deliver accessible information to ethnically diverse communities around the UK. A couple of examples here, for example, and really, the scope of what I want to talk about today is, some of the approaches that we took and why and what our learnings were from our experience. So this is a statement that just might sort of come across quite obvious, in that people are more likely to accept misinformation as fact if it's easy to hear or read. Our first step when we were looking into how we could sort of make information more accessible was to get it translated, deliver it to people in their native language, because what we saw was that a lot of the misinformation articles which were being sent through to our communities and our friends' communities were in their native language, making it easier to understand and to take on. This was similar to efforts being made by organizations such as Doctors of the World, BBC Asian Network were putting out videos in South Asian languages, and we sort of took a very similar approach, but tried to condense it down into one place, so that it was all the information that was required in one area before it was sort of shared amongst our network. This has been hinted at plenty of times, and the next step for us was the critical one, which was building the relationships. And like what's been mentioned already, we need to understand that a lot of this, the acceptance of misinformation, or the taking on of misinformation, is happening in these communities in the background of these poor sort of pre-existing relationships, not only with the government, but also with the healthcare system. So misinformation turns out to be not only sort of a cause for this, but also very much a symptom of it as well. As these are graphs taken from the Royal Society of Public Health survey, and also this fantastic article by Hope Not Hate, where they sort of did a survey for a number of individuals from these backgrounds, asking what level of trust they place on various groups. Now, the great news is that there's already fantastic grassroots groups and individuals with the infrastructures in place, with the relationships with the various communities in place. And by us sort of reaching out to them, having this conversation with them and providing them with the information, not only were we helping to sort of keep them informed, but we're also offering them the language to facilitate the conversations between those within their close circles. And like what's already been mentioned, this top-down approach, it doesn't really go far at all. Instead, by doing this and working with individuals with these relationships already, we're allowing this continuous forum where individuals from the community could come and have these conversations. And by having this two-way sort of communication, we were also trying, hearing, what sort of misinformation was rife, what the concerns were, and trying to feed into that. So whilst to begin with, we were generally just information provision, we'd started to turn towards working off of hearing what communities were wanting and trying to offer that and trying to personalize that information. Like we've also seen, the younger generation were fantastic in trying to get our work out there. We've seen with Noreen's work already just how much work they're able to do, and sort of how innovative they can be in sort of having these conversations. And often they were the vehicles for us for getting us into sort of the exclusive WhatsApp group chats where the misinformation enters before it is spread throughout the community. One of my favorite graphics, which refers to the approach that is going to have the most impact, is the one that was shared by the NHS Race and Health Observatory webinar, where they talk through that. This is only half of the graphic, by the way, but they talk through the steps by which to approach this. And obviously, building trust is the biggest one, and this is going to be the most time intensive and energy intensive one, before offering clear information, being consistent with that messaging, and continuing to engage and maintain that relationship. Now, another part of our approach was trying to bring some awareness to misinformation as well within the context of the pandemic. I think for a lot of individuals, whilst it might seem obvious to ourselves that that misinformation is very much a thing that we need to be aware of, for a lot of people, it's information that's being delivered to them that they're happy to take on because it comes across as fact, by the way that it's portrayed. So we did a lot of work to try and raise some awareness for people to be able to recognize it, to what sort of questions they should be asking whenever they get put in touch with these articles. This was a talk that we delivered to a community of about 500 strong individuals from the Tamil community based around the world, and essentially, although this was a one-off talk, it became clear to us that that messaging needs to be continuous to make sure that people are aware that this is an issue. We're actually in the process of putting together some resources to help various communities identify and counter misinformation as well. Other bits of learning. So I've already hinted at a few of our learnings, but other things that we need to sort of be wary of is that information overload and fatigue pretty much applies to everyone. We saw a fantastic response on the back of some of the articles about how the false news was or causing this or contributing to this vaccine hesitancy. And what we then saw was a response from healthcare workers all over the country, putting together videos, feeding it into social media platforms. But we need to also remember the flip side of this as well, which is that there's a sphere of information which is continuously being fed into, not only with sort of the correct information or the consistent information, but also with the misinformation as well. And it can become quite overwhelming quite quickly. So what we found sort of worked for us was working within our sort of own spheres of influence, working within our own spheres of trust, collaborating with various organizations who have their networks and in order to get this information out there. And we've done some fantastic work with various organizations, so the South Asian Health Foundation, Doctors of the World, and one of my personal favorites, just because how ingrained in the community was with this the Punjabi school SSEC based in Southall, where we sort of utilized our resources as part of their learning of the Punjabi language, translated it, and then were understanding and spreading it among their own sort of families and friends. So like I said, it was another aspect of the work we were doing. And finally, I think one of the things that we just need to be wary of is that the digital divide very much exists in this country. We've been part of conversations with various strategic migration partnerships where we were hearing about their service users not having access to the digital world, understandably. And you realize that to reach out to these particularly marginalized communities, you cannot always go down the mainstream channels. At which point, again, having that forum for them, or being able to provide that forum for them to have a discussion, was vital, and also obviously trying off digital approaches as well. So to round up, really, I've decided to try and summarize the approach that I hope we could look to take going forward. And I've taken some inspiration from the Build Back Fairer report, where they sort of divide it into short term, medium term, long term. I think in the short term, the vaccine messaging, it's been fantastic, and it needs to continue. And in doing so, we need to continue to build on sort of the accessibility and the relatability of the work, not only sort of making it culturally tailored, but also making it sort of regionally tailored where there's variation. One particular group, we've heard about a group that's done this already quite well, but another particular group, Maslaha, is a group based in Newham who's been doing fantastic work, in relation to this as well. And unfortunately, in the work that I'm doing at the moment, over the past 2 weeks or so, we've seen a return of cases of hospitalizations due to COVID. And it's painful to see that a lot of these are individuals who haven't been vaccinated. And unfortunately, those who are being fast-tracked or who are becoming quite poorly with it are those from the minority backgrounds. We're seeing entire families come in who haven't been vaccinated, who are still coming in. And it's much more difficult to take, especially when they're, appears to be, when there is a solution available. Now, on the sort of lines of that, we should also look to share the success of the vaccine among the various sort of diverse communities. It's clear to us, from those being from scientific backgrounds or those who have been following the news quite routinely, that the vaccine is doing its job. We're not seeing nearly the rate of cases we're seeing at the moment is not nearly the same as what we've seen in past waves. But we need to sort of communicate that as well to those in these communities, just to build their trust in the science as well. And in doing so, continue to build this network, continuing to reach out and keep the various communities involved. On from that, looking into tackling misinformation at a community level is going to be vital. The world is becoming increasingly digitalized, and it's going to be an issue going forward into the future, not just in healthcare, but also, looking into politics and other areas. So being able to share how to identify and how to sort of critically analyze these articles which are coming through at a basic level is something that should be looked into. And then sort of building an organization, building organization into the relationships that are being built in this campaign as well. I mean, from our initiative, we've been in constant communication with close to 100 to 150 organizations, and it's difficult work, not only just sort of maintaining that line of communication, but also building that relationship as well. And in the long run, it will be fruitful. If we're able to achieve this and do this effectively, we're able to then utilize this infrastructure to then try and challenge and address some of the sort of deep-rooted structural racism which has impacted the relationship between these various communities and the healthcare systems and, and other systems over the past decades. And, it will allow us to put the needs of marginalized communities in front. So I just want to round off by saying a big thank you to my team, fantastic group of individuals from various backgrounds, to our amazing translators who've dotted around the world, and the organizations who've supported us. If you want to follow our work, there's our various sort of social media handles. And like I said, we'll be putting out a few resources in the sort of the scope of misinformation as well. So thank you very much, everyone.
Well, thank you very much, Venu. That was really fascinating. And I think it really, we're all sort of very aligned in the fact that what's really important is to work with communities and actually understand them and make sure that we're addressing the messages, particularly to the groups, rather than just having a one-size-fits-all. I'm just going to now open up for questions and answers, and we've got obviously some questions that have already come into the Q&A. First of all, I just want to make it clear that some of the questions that have come in are very specific in relation to individual questions and individual needs. And I would say that this isn't the forum for that. What we're actually recommending that you do is go to speak to your GP if you've got some specific concern about a health condition and in relation to whether you should have a vaccine or not. So that's not really the channel that we're having here. Go to seek advice from your GP. One of the questions is quite interesting, and it's about what is the role of the media, and have they had any responsibility for misinformation themselves? I just wondered if anybody would like to start us off with that one.
If I may, Lisa, yeah, I thought this was a brilliant question, and certainly an issue that we came up against a lot of the time, John Davey, who asked this question. So what we found was that these inner city communities from predominantly BAME backgrounds, now we know that a lot of them don't watch mainstream media, so the terrestrial channels, and yet they all have their satellite channels. No matter how long they've been in Britain, for example, they are still watching their home-based channels. So for people from Pakistan, we'll be watching your ARY News or PT Pakistan TV, and that's just a general cultural nicety that they have their connection with their grassroots families from other countries. Not a bad thing, really nice, keeps the younger, if you're living in an intergenerational family, it keeps them all connected with your culture. However, where it was going wrong in Britain was that all of the messaging, whether it be NHS, whether it be government, scientists, clinical, it was coming through mainstream channels. There was no code of conduct or responsibility coming from these satellite independent channels to ensure they are giving out the same information in sync with mainstream. So some families may never put on BBC One or ITV, but yet they will always have their mainstream. And so we decided as a group that we were going to approach these independent satellite channels. And I can absolutely confirm to everybody that not one independent international channel responded to our pleas to either have our students on air, on the telephone, talking to the masses that we knew held the majority of the communities that they were watching, whether it was Bangladeshi TV, whether it was, a Sikh TV, whether it was a Muslim community, Buddhist community, the Black community, none of them would respond to us. So there should be some form of code of conduct or license or something that they should be sending out those pro-vaccine messages. And even the hands, face, space, stuff like that should be a regular on there. So that was one of the main things I wanted to get across, John, when you asked that brilliant question, that I absolutely feel that the non-mainstream channels that are holding the majority of people's mindsets and time in inner city communities need to be doing better. The mainstream were doing great in, getting the BAME celebrities, were doing some fantastic adverts, but it wasn't getting to the people that needed it.
Noreen, were you actually finding that there was misinformation going out on these channels?
Sometimes I think no information is worse than misinformation. Misinformation gives you the chance to at least give that counter narrative and have a discussion and open up. Because what we've got to make sure is that we don't block out alternative voices. As dangerous as misinformation is, I do find that no information is worse, because that allows for the conspiracy theorists to evolve with their own answers. Whereas having conversations, I think, is important, because that brings in the education and allows that power of influence dependent on how and what is being said. So I certainly think that no information is worse than the misinformation going out. And unfortunately, these independent international channels didn't allow anyone or any information to come on their channels.
That's really interesting insight, actually. Has anybody else in the panel got anything they can add to that?
If I could just add to this, it's a great point, and we certainly saw something very similar amongst the Polish community in the UK, that at some point which is, by the way, one of the most hesitant minority communities in the UK. At some point, we just realized that a lot of news that they are getting about COVID, first of all, the pandemic, and then the vaccination programs, actually does come from these conspiracy theory websites from Poland in Polish language. And it was very, very difficult to reach out to these communities, to actually talk to them with the kind of mainstream media. So the best, absolutely the best approach, if you can't get to the source of it, actually stop it at the source, or kind of do something about it at the source, is actually to develop these campaigns in the local language, understanding the local culture and what actually matters to these people and what shifts their opinion, and actually address it locally here in the UK, using the local language, is the actual language of the community, and having the understanding of the cultural differences. I just want to absolutely reconfirm what Noreen was saying. We saw a lot of that as well in our research.
So how did you actually go about helping the community? What were your methods then to infiltrate the right messages?
It always starts with research. So you need to understand what actually drives this hesitance or non-acceptance of the vaccine. You need to start asking these questions. So social media does help us, because people actually express these ideas, why they're hesitant. So by conducting social listening, we can pretty much tell what actually drives that hesitance. And once you've got this data, once you understand what actually drives it, you can actually develop messaging that addresses that very specific issue. And this could be very, very different for different communities. For some of the people, it could be based on their religion. For others, it could be based on the concerns about health. But without having that understanding, this kind of micro-targeting of these communities in countries such as the UK would be absolutely impossible. So just to reinstate that, research and digital research is absolutely the first thing we should be starting with.
Thank you. Has anyone else got anything else to add on that? Okay. Okay, so what I'd like to really raise now is a question about, are some age groups more susceptible to misinformation? And I just wondered if any of the studies that you've done have identified that.
May I, without risk of overdoing it? So what we're finding now is our program utilised the young people to persuade the middle-aged and elderly, if I may use those terms. But we found that it was predominantly those at the time when we were trying to roll out the initial vaccine, pro-vaccine messages. So now that it's taken us almost a year to get to the point where we know that everyone has kind of bought into the virus, and now we're forecasting and understand it's going to be about a year to a year and a half before we've fully got everyone convinced over the vaccine specifically. And we're at a point now where it is this young people. So where using the young people to persuade the elder generations was slightly easier, because we found that for some of these families, it was the first time their young people, their grandchildren, their children were going to university. And that was these young people that we were training to be COVID public advocates. Now what we're looking at is utilizing the same model to start working in a peer group style. So we need to keep these young people that are upskilled from health and social care backgrounds that are going to be the new workforce for the NHS predominantly. And it's about, I feel, and what we've heard from ground research, is that these young people are going to be instrumental in persuading and influencing their peers and the younger generations to the uptake. Because now if we're going to get all middle-aged clinicians and community advisors or local authority people sitting in ivory towers, I'm sorry, but the influencers and the millennials are not going to buy into that. It's got to be their own peers who are at university, who are on social media, who are these TikTokers that do these fantastic 30-second things, but that's what they're going to buy into. So we need the investment to be pulled into creating innovative projects that are focusing in on young people, which is why I'm so upset that youth services have been cut down so much, because this could have been the time where youth services became instrumental in putting out the positive notion of the pro-vax message.
That's a really interesting take on this, and you know, I've got 3 young adults, and I can see the influence of the peers, and also, you know, we've even got a point where it was fear of missing out. A load of them went in the car to get a vaccine. Only 2 of them were going to out of the whole carload. And then by the time they got there, they all got caught up in it, and they all ended up with the vaccine, much to my delight. So, you know, I think we've got to understand who we're talking to. That's what it comes down to all the time. And I think, Melvin, you know, that's where you were coming from with all this.
That's right, Lisa. And I think in addition to having less familiarity with social platforms than younger generations, older people tend to have fewer people on the edges of their social spheres, their social networks, and they tend to trust the people they know more. So when they get these messages from WhatsApp, from Viber, from Facebook Messenger, from their close friends, they tend to think that these messages are actually factual because they are from trusted people.
Mm-hmm. So we've got to get under the skin of this, haven't we, to get success. Yeah. There's a question here about how do we get the opinion and faith leaders to want to work with us in sharing correct information and not with anti-vax teams for financial gain. So anybody got any thoughts on that? I think that's probably one for you, Noreen.
Yeah, and my opinion on this is probably going to be like Marmite. People are going to agree, people are absolutely not going to agree, but it's a risky one, because with faith leaders as well, we've got to ensure that they are audited as well, that they are profound and registered and they are knowledgeable, because you know, there are some people out there that could say, I'm a faith leader. If I sat here and said I'm a faith leader, Lisa, you wouldn't question it, you would take it on face value. But there are real ethical understandings that need to be taken into what do you class as a faith leader, so that they are not going to side and partner with these anti-vaxxers or money making. I too myself have been caught up in situations where we've wanted to do projects or spend some time in a local faith institution, and despite them being a vaccine centre, given money to put on be a vaccine centre, there was very limited access into the centre to kind of do any community engagement work, and it makes you question why. So whilst I agree that they do have a huge responsibility, I don't think we can just openly say it should be down to all faith leaders, because we are at risk of them siding with the anti-vaxxer or not being there for the right reasons. Yes. So another brilliant question, but something that we really need to be aware of.
Yeah, that's really good. Anybody else got anything to add? Okay, so we've got a question here about how can you control the misinformation shared on mass media with personal agendas? What can we do about this? Anybody got any thoughts? What could the government do about it?
I could try. I think the easiest answer is that we have to accept it that we will never ever be able to fully control that. The mass media or the digital media, including the BBC and obviously the social media, is a big market of opinions, and it should absolutely remain like that. It should be a market of opinions. We just need to be able somehow to filter out those opinions that could be harmful to people, and that is a massive task. I think that we're only starting this discussion as to how it should be regulated, what could be done about that, and there's obviously a risk of getting into very dangerous territory of trying to regulate freedom of speech and freedom of expression and all that. I wouldn't be so brave enough to actually answer this question today, but I can tell everyone that these discussions are starting now. People are realizing the actual impact of misinformation, and that something needs to be done about it. But as to what the actual practical solutions are going to be, we've tried, we historically saw deplatforming of certain individuals in the US or in the Western world. We tried that approach. I mean, the platforms have tried that, and we're now learning what are the implications of that. We obviously having these discussions about the algorithms, how those work, how they actually recommend content to certain people, certain groups. And obviously we are still at the beginning of this discussion. What can be done about these algorithms, how we should start these conversations with big platforms to make sure that it doesn't happen algorithmically. So we are at the beginning of this discussion. I wouldn't say we've got answers yet, but I'm pretty sure we will get some answers very soon.
That's very helpful. Thank you. Anybody else want to chip in here? Yes.
Bobby, after you.
Sorry, Bob.
You going first? Okay. Thank you, Lisa. Yeah. So it's as I understand the question, I think it's talking about mass media, as in mainstream media, as well as the platforms, and that's a really interesting question, because I think again, on the one hand, we shouldn't lose sight of the positive, in the sense of what shines through in our results is that people who do engage with the mainstream media do have a more balanced and positive view towards vaccination in particular, and then general restrictions and how we've been dealing with the pandemic. So I think there's been a positive impact from some aspects of how the mainstream media dealt with it, but equally we are still learning lessons. And I think one of the lessons that vaccination in particular really brought home to some of the mainstream media outlets was the real danger in what was called balanced reporting, where you would put one side of a case, so that's the scientific consensus, or the vast majority of people have that, but then you give space to the really fringe ideas or discredited ideas. And that obviously came up particularly around the MMR programs that were done around then. And that was a real wake-up call, I think, to people, that balanced reporting is really dangerous, because what happens is people don't hear both sides of the argument. They remember and are influenced more by the extreme side of the debate. So balance reporting in that sense is a myth. And actually, a lot of moves towards, can we have more solutions focused reporting, which lays out these types of arguments, but works towards what's the solution. And BBC in particular being very focused on that. And that type of agenda needs to be further developed. How do you have those conversations without inadvertently, given the biases that we all have as humans, pulling us in particular directions towards negative or scary information? That needs to be accounted for in how you approach that. So that was and that shines through, and I do a lot of work on misperceptions more generally and how people are affected by these things. And it's the interaction of the information environment with human biases that you need to understand. It's not neutral in any direction, but it is a system, and you need to treat it like a system where just intervening in the media environment on its own is not enough. Just intervening on people's biases and working with them is not enough. It is how those two things interact.
Thank you very much. I think that was actually really insightful. I know if you have a toddler and you tell them not to do something, they'll go and do exactly what you told them not to do. So I think this behavioural knowledge is so important. So unfortunately, we're just running to the end of this amazing webinar, actually. Thank you so much for all the questions. I'm sorry we haven't got through to all of them. I presume that the chat will be kept with the webinar recording. So there are some good links there that people have put in, and some excellent comments. So I just want to thank you all for this wide-ranging and thoughtful discussion. It's the last in the current webinar series, but later in the year we'll be bringing out new sessions. So do keep an eye on the social media pages on our website. If you're a member and you'd like to offer a webinar, blog or piece for the RSPH, that would be great. Please email us. And if you're not a member, then also email engagement@rsph.org.uk. And I would urge you to join, because it's not very expensive, and we're a fantastic, all-inclusive sort of, a very inclusive, I should say, not all-inclusive, sound like a holiday program. We're a very inclusive charity, and we like to engage with people in all health aspects. So please do join if you're not already a member. So finally, just thanks to Bobby, Simon, Noreen, Melvin and Venu, and all of you for joining us today, and we look forward to seeing you at future events.